It is just a huge honor for me today to be podcast interviewing Joel Howard Berg. Thank you so much for coming by.
Good to see you, Howard.
We've been friends for 30 years. He's a professor and Lloyd and Kate Chapman Chair for Oral Health at the University of Washington School of Dentistry in Seattle. Dr. Berg is a board-certified pediatric dentist and was president of the American Academy of Pediatric Dentistry in 2012. Dr. Berg previously held positions as Chair of Pediatric Dentistry at the University of Washington from 2003 to 2012, nearly a decade, as Vice President of Clinical Affairs at Philips Oral Healthcare Sonicare from 2000 to 2003, and as head of the Scientific Department for ESPE Dental Seefeld, Germany from 98 to 2000. He is the author of the book Early Childhood Oral Health and of over 100 manuscripts of book chapters on subjects including dental restorative materials for children and other work related to biomaterials. His current research interests include the development of dental caries prevention programs using risk assessment models in early childhood oral health. You know, I've been a huge fan of yours forever. You've been to my office. I got lucky one time. I was coming back from a seminar, and I go sat down in my seat, and I sat right next to you. Do you remember that?
Sure, I do.
And poor Joel, he thought he was going to get a he had his laptop out all ready to work, and I yacked at him for the whole 3 hours.
I enjoyed it. I remember that conversation. You talked to me a long time ago about doing this.
Yeah.
So I'm glad I'm here.
You know, it seems like when you look at spending of money, children, I mean, the meaning of life is to survive long enough to reproduce. And moms would rather, I mean, I'd give my kidney to any of my children or grandchildren. And pediatric dentistry is everything. And so many grandparents, I mean, grandma doesn't want veneers. She wants braces for her granddaughter, you know. Mm-hmm. So you're sitting at really the junction of meaning of life and dentistry, pediatric dentistry. But gosh darn it, if... At least men my age, if you said, what's the one thing you never want to do? It's pediatric dentistry. I mean, the dentist would rather do a root canal, a filling, a crown. Has that changed over the years?
Well, we're seeing a lot more interest in pediatric dentistry. It's if you look at the ratio of applicants to people accepted into specialty programs, I think we're either the highest or the second. We're up there.
The most competitive.
The most competitive to get into.
And what is the ratio now?
I think if you look at the total number of unique applicants, because people apply to multiple programs, and the number of positions, it's around 3 applicants per position.
3 to 1 to go to ped grad school?
Yeah, and I think it's probably in the same range, or even a little higher ratio than orthodontics or oral surgery, for example, or endo, which has a low number of positions. Has, you know, it kind of excludes people who realize they have no chance because there's a low number of slots. So we do have we have a larger number of positions each year nationally.
Now, I heard that the United States has 325 million people, and they don't even have 300 slots for a pediatric dentist, so it's less than 1 out of 1 million.
I think it's a little more than 300 now. It's been corrected. It's right. It might be around 320. I don't have the exact figure.
Well,
I can get that for you.
Yeah, 320.
But it's almost doubled in the last. But it's still low. You're right. It's still very low.
Well, in a country with 325 million people, that 320 slots means we train 1 new pediatric dentist each year for every 1 million people.
It's a good way of putting it. You know,
that doesn't seem.
And if you make a comparison to medicine, where most parents take their kids to a pediatrician as opposed to a family physician, it's the opposite in dentistry. About 65-70% of children are seen by general dentists, which is a good thing because it's family practice, and only 30% or 35% are seen by pediatric dentists. So it's not the same scenario as in medicine.
The really sharp pediatric dentists, the slow ones to marketing, they're always marketing to general dentists to refer to pediatric patients. And the smart ones say, forget that, I'm going right to the pediatricians, the OBGYNs. They're picking off these new patients right when they're made. I mean, as soon as they come out. I tell pediatric dentists, don't focus on the general dentist, because he's going to send you the one they've already scared, that's crying, bad behavior. And so you're going to get just it'd be like an orthodontist only getting class 3 malocclusions.
Right.
To get that 80% class 1 malocclusion sweet spot Invisalign case, go after the pediatricians.
Yeah, I think you're right. That's most of our referrals come from pediatricians, but I would say to those general dentists, and as I said, the majority of kids are seen by GPs appropriately. I think it's part of a comprehensive practice, and there's an advantage a general dentist has because they can see the mother, they can see the father, they can see the caregiver, they can see the siblings, they can see the whole family. And oral health is a family issue. So when you talk about behaviors, it's important to have the whole family. And So to a certain extent, there is that advantage. As you just said, pediatric dentists often get referred from GPs patients who didn't survive in the practice, and maybe it becomes even more difficult to treat them afterwards. But I think the connectivity is always going to be important. I mean, pediatric dentistry is unique as a specialty. The other 8 specialties of dentistry, there are 9 total, the other 8 have a specific discipline that's carved out. You mentioned endodontics or periodontics. Or
yours is just small humans.
Exactly. Ours is about a population. And the beauty of pediatric dentistry...
About a population.
A population of children being the population.
I mean endodontists do root canals, oral surgery do surgery. Pedodontists just do the small humans.
Yeah, small humans and people with special needs, and we like that, and we like the fact that it's beyond the dentistry. We can shape the behavior. I argue with people all the time, and my best buddies in my industry days, I got to know a lot of prosthodontists and people who use impression materials, and I learned all about scanning. I'm the incoming president of the American Academy of Aesthetic Dentistry, which is anomalous for a pediatric dentist. They look at me like, what are you doing here somewhat, but it's a wonderful group of people who perform some of the highest end dentistry. But that group and others realize that dentistry as a profession is about excellence and doing the right thing for populations. And I argue with all my buddies, whether they're prosthodontists or general dentists, that the most important visit in the dental office of one's lifetime is the age 1 dental visit. And I can argue till the end with anybody on that one, because where do you get a better chance to shape the behavior and prevent disease than at an early age? And I would tell a general dentist, if you want to measure the health of your population, lower the median age of your practice. Because the earlier you get them in, the younger you get people in, the more chance you have to shape preventive behavior. Because caries, the most common disease in humans, is a behavioral disease. It is. It's preventable. Unlike all childhood diseases, diabetes, asthma, you can't prevent those. You can manage them. But in the case of dental caries, we can actually prevent it if we provide the information and the experiences that are going to be important to keep this child cavity free for their life. So that age 1 dental visit, nothing more important in one's life.
One of my favorite quotes, "It is easier to build strong children than to repair broken men."
True.
By Frederick Douglass.
Great quote.
It's everything. You've said so many things. The thing it is a family disease. The thing that bothers me the most about pediatric dentistry is seems like about every quarter someone a general dentist can't work on this child behavior, whatever, since a pediatric dentist says, we can't manage it either. We got to drag this patient to the OR. It's only 2. It needs 8 pulpotomies. And a board-certified pediatric dentist and a board-certified anesthesiologist put the child down, and they lose the child. And then it's all over social media, and I find it so grilling because the media, the dentist is always the bad guy. Mm-hmm. I've never heard one media person say, "Hey, mom," and the mom gets several million dollar bonus reward for having a 2-year-old that needs 8 root canals. So she wins the lottery of money, although losing her child. And nobody ever. There's no journalism in America. I mean, we just had the driverless cars. Mm-hmm. So Uber in Tempe, they had
the accident here.
Yeah, their first accident.
But that's nothing compared to the number of accidents that occurred by us.
But that's not in the article. That very day, 100 people were killed by humans driving cars.
Yeah.
There's no in-depth journalism.
I agree with you.
And they never ever go in and say, "Mom, how did you manage to have a child that needed 8 root canals at age 2?"
Right.
And
that's why I go back to the prevention.
And if this woman gets $2 million or $3 million, it should be given to a dental school to do oral health care deals. And then the other thing that bothers me the most about pediatric dentistry is a 2-year-old needing 8 pulpotomies, grumsel crowns isn't because it ate some Cheez-Its and cookies. This is, it's because dad has a bombed out mouth and he's kissing the baby, and grandma's got gum disease, and people know the waist down, all those STDs are transmitted. And AIDS clarified that for the planet, that man, you can pass germs downstairs. And they haven't even started the discussion. The other end of the body, you have a newborn baby and you hand it to grandma who's wearing an upper and lower partial and has gum disease. Grandpa's got bombed out molar and they're kissing the baby right on the mouth.
Well, you're hitting all the right points, Howard. I think It's a behavioral disease. And, regarding what you said before, it's unfortunate that any child would die with anesthesia for any reason. But the fact is, in looking at the American Academy of Pediatric Dentistry guidelines for sedation, which are in common with the American Academy of Pediatrics, went together on those. When the guidelines are followed, there's never been a death. So I think it's important to know that there are guidelines, there are ways of practice to prevent those things from happening.
You think these deaths aren't from board certified?
Well, I don't know about each instance, but I think
humans had two in the last.
Yeah, I don't know.
3 years.
I don't know. I've heard about those. I don't know the
Arizona.
specifics. Yeah, it's unfortunate that it ever happens. It should never happen. That's why we go to great lengths to develop training programs and guidelines. And
but I'll call Uncle on this. There's only 3 publicly traded dental offices in the world. There's none in America. There's 2 in Australia, 300 Smiles, Pacific Smiles, and Q&M out of Singapore. When they did their IPO, the lawyers looking at claims, these companies are not allowed to do. Almost all the deaths are between birth and 16 years of age and 65 and over.
Yeah.
So their oral surgeons
higher risk patients
can only do patients 17 to 65 or 17 to 65 because obviously anesthesia on a 2-year-old is 100 times more risky than on a 25-year-old. Agree or disagree?
It's I don't know about 100 times, but it's definitely riskier, and that's why we have careful guidelines and we have certain age limits or age requirements. So we would rarely, if ever, do anesthesia on an 18-month-old, okay, or a 12-month-old. But 2-year-old to 3-year-old who has 10 or 15 large cavities with facial cellulitis, evidence of a real health risk that could kill the child. It would be very dangerous to the child. That's seen every day in every city in the country. We have to do something about that. And from a behavior standpoint, I call children under 3 not uncooperative, but pre-cooperative. They're not supposed to be cooperative. In medicine, if you had to have tubes put in your ears, you wouldn't even think about not doing general anesthesia. Although, having observed hundreds of those procedures myself, that's a heck of a lot easier than what we do. You could hold the kid for a few seconds and do that, but it would never be considered. So it really boils down to a question of medical necessity. If this is medically necessary, these procedures, and they are in these instances, then we have to do what is necessary to provide the medically necessary care. So to me, it's a question of, is oral health part of total health? And if the mouth is part of the body, then you don't ask the question, well, that was only dentistry, why do we do it? Is it medically necessary, is the question. And then you deal with the same issues of safety that everybody deals with, regardless of the procedure, whether it's the ears or the feet or whatever it may be. So the question shouldn't be about dentistry. It should be about, is it medically necessary? And sadly, as you said earlier, because the behaviors weren't there to prevent this disease, which is almost entirely preventable, it becomes medically necessary to preserve the health of the child. That becomes the issue. That's what our age 1 visit is about, providing that information to parents. Unfortunately, the ones who come in sometimes are the ones who maybe don't need to come in. The ones who come in at age 1 are the ones who don't come in are the ones we want to get to. And by the way, general dentists, we've trained thousands of general dentists across the country. In Washington State, we have a program called ABCD, Access to Baby and Child Dentistry, a very successful program.
Wow.
That's improved access to health for babies. It's an amazing program. And other states have programs like that.
What's ABCD stand for?
Access to Baby and Child Dentistry.
Access
to Baby and Child Dentistry.
Okay.
And it's a very successful program that has resulted in, for example, Washington State used to be one of the lowest access to care states for kids in the country. Now in Washington State, as a result of ABCD, it's one of the most likely states for a child to have access to dental care because of and it's all education and promotion and consumer awareness and health literacy is what this is about. Medicine, they talk a lot about health literacy. I think that's one of the most important subjects in dentistry for health because you talked earlier about the parents. You're right. It's all that. If the mom's got dentures at age 50, they have a lot of cavities in their mouth. There's the transmission part. You referred to that. But and by the way, that's a whole new subject, which is fascinating. We're just learning about the oral microbiome. I just was emailing some of my buddies who are the top microbiome people. Many of them not dentists, some are. But I think that's where all the discoveries are going to get made that are going to change our profession. They're going to just change everything we do, and we learn about that microbiome in the mouth. But it's about access to the families.
It's not even Well, first of all, it blows my mind that there's dentists on Dental Town that don't believe it's transmissionable. I mean, it's like
it's scientifically proven.
So if you just walk out in the backyard and there's a giraffe there, it just appeared. What, the tooth fairy bring it? Don't you think that giraffe came from a mom and dad, and they came from grandma and grandma? But But when you said microbiome in the mouth, I've already read a ton of literature that maybe the biggest factor of the microbiome in the mouth is the microbiome in the sigmoid colon. The 30 feet from your mouth to your rectum has 100 million bacteria, fungi, viruses, microorganisms that you didn't get from mom. Whereas when Joel, we'll just call you Howard because your middle name is just perfect. Joel Howard. When you look in the mirror, what you see is 10 million cells that you got from mom and dad. But from your mouth to rectum is 30 million, and they think that so that whole cord is connected.
Yeah.
So if you have a lot of pathology going on in the mouth, I mean, it is amazing. I think they're the number one transplant in the world right now is a fecal matter transplant.
That's a big transplant. It's important. It saves people's lives all the time. Well,
and then the other thing about the oral microbiome, when you start telling me about this bacteria, that bacteria, when you say that, are you aware that every 90 days they discover a new bacteria in the mouth that they didn't even know of before?
Well, yeah.
And when people say that the cavities are caused by Streptococcus mutans, did you know that 4 millimeters down in the decay, there's not even any Streptococcus mutans?
Well, yeah, that's all.
I mean, it's all new.
There's so many facts that are really interesting, and I think the amazing thing about the microbiome science is people have theorized for years. Miller, who was the first dental microbiologist who worked in Robert Koch's lab in Germany, who talked about the bacterial transmission disease in 1882. Miller, who was this dental microbiologist, if you will, proposed the oral systemic connection that we talk about today. And he made all these theories, most of which are true today, but he couldn't prove it. So what's interesting is the laboratory science, the actual ability to perform the experiments in the lab, the genome science, the sequencing techniques, 20 years ago you couldn't have done 23andMe because it was too expensive. You couldn't do it at all. 10 years ago it was too expensive. Now you can do it for $75. We got our dog. We adopted a dog who was injured here in the next county on Christmas, and we don't know what breed she is. So on Amazon, we bought a kit for $75, $50, and I can find out what breed this dog is, what hybrid breed the dog is. Okay, that would have cost $10,000 5 or 6 years ago. So the techniques and the cost effectiveness of the laboratory techniques that allow the scientists to make the discoveries are improving every week. So I stay in touch with these lab guys because they've had all these theories for years, but they can't prove them until the lab science catches up to allow them to do the experiment. So to your point earlier, they say there are 500 plus species of bacteria in the mouth, whatever number you want to propose. Some people say 1,000, but let's say it's over 500. But what has been known for some time, only about a third of those can you grow in a petri dish, whatever you call it, in the culture. Right. The other 2/3, we've never known they were there until we could see the RNA and DNA. Now we know their presence. And now, with modern techniques, some of which have only been developed in the lab in the last year, you can actually see the sequence of events that occurs when you feed sugar to this biofilm. And you can see how it really acts like a community, in the same way that the pituitary gland sends a signal when you're scared to the adrenal gland to make adrenaline. The adrenaline doesn't come by itself. It has a signal, a hormone signal. The biofilm acts in the same way. So strep mutans, we know it makes acid, but now we know that it needs a signal from something else to turn on that acid production. These guys are communicating. They're talking to each other. I always say in my lectures, Howard, that I'm not actually speaking to you right now. It's a biofilm that's occupied my body because it needs vocal cords. I should make a movie about that. I think it'd be a bestseller. Because the reality is we have 10 times as many bacterial cells in or on us as we have human cells.
Right.
We are mostly bacteria. So we interact with one another. To your point earlier about the fecal transplant, if you don't have it, it'll kill you. We need each other to live. We coexist. We understand very little about that coexistence. So all these discoveries about the oral microbiome are going to shape the way we think about caries, because now we know there are these new bugs, for example, Veillonella is one genus, that seems to turn off the acid production. So maybe we don't focus on killing the acid production by killing mutans. Maybe we figure out how to uptick the ones that are good that say, hey, we don't want that acid production. Let me just shift gears, if I could, for a second, a related subject. And, it's a little superficial, but I think it tells the story. You mentioned the GI tract, from the mouth to the rectum. The gastrointestinal business, the whole gastrointestinal disorders business, is about 100 billion a year in the U.S. Caries by itself is about 125 billion. I mean, dentistry is the business of dentistry is about 160 if you include all the medical costs, 170 billion. Caries is most of it. Most of dentistry is dental caries. That's the disease that we treat. And then you have periodontal and you have other things that we deal with. But most of what we do, we're cariologists. We're cariology clinicians, because everything we do is treat the effects of caries. We don't actually treat the disease. We treat the effects, and that's most restorative, most pros. Everything but perio is pretty much the effects of restorative. In medicine, you have, for example, medicine that deals with most of gastrointestinal disease, not surgery. And the whole field of medicine is mainly medical management, not surgical management. But dentistry is mainly surgical management, waiting for the results of the disease, that is, the broken down teeth, etc., rather than treating the disease itself that causes that problem. And there's a drug called nexium. You've heard of it, I'm sure. It's for esophageal reflux. It's over the counter now. The last year was by prescription, I think about 2 years ago, something like that, maybe 3 at the most. They sold in the U.S. over $6 billion of nexium. One pill, $6 billion. Second biggest dollar-selling pill in the United States.
What's first?
I think it's a mood-altering drug, and I can't remember the name of it. It'll come to me in a second. Abilify.
Abilify is number
yes. Abilify was number one. I don't know what it is today, but it's probably near the top, and I believe it was number one. So anyway, but nexium was number 2. Okay.
Do you know what 3 was?
I don't remember, okay. but I can get you the list.
Yeah, Ryan, Google.
I'll send it to you. Yeah.
Okay, Google by dollar amount.
Okay, yeah, but it's by dollar sales. Yeah, this is not by volume.
The top 10 prescriptions by
dollar
by dollar amount. Top 10 prescriptions sold in the United States by dollar.
Yeah, because if this is by volume, it's going to be antibiotics and things that are cheap.
Actually, the number one by units has been hydrocodone for 20 years.
That could be, because they're cheap, to purchase, but not on the street, but to purchase by
I mean,
generic.
most prescribed.
Yeah, I believe it is by volume. Yeah. That makes sense. But by dollars, you're spending, 6% of the total gastrointestinal disorders expenditure in that year was one pill. Now, if you compare that to dentistry, Dentsply just merged with Sirona. There's a $5.7 billion company. So everything that Dentsply Sirona does is less sales than one pill in medicine, nexium.
Nexium, wow.
And that says a lot about the profession, because most of what Dentsply Sirona does, good things for us in the profession, is to deal with restorative treatments. So if you think about it, they're preparing us for surgical repair of teeth. But in medicine, you have a big drug that manages it medically. And I'm not saying drugs are the answer, but it's about the perspective. So what does nexium do? Nexium stops acid production in the stomach. It's a proton pump inhibitor. So it goes through some biochemical pathway and interrupts it to prevent acid production. But caries is acid production. So in the former case, you take this pill, nexium, it somehow makes its way to a process which occurs in the stomach and maybe distal esophagus and stops this acid production. So why can't we do the same in dentistry for caries? And so I think these discoveries that are going on in the lab, that the scientists who I try to stay in close contact with are looking at the microbiome, they're looking at how to interfere with acid production. And that's ultimately how drug development occurs, and how the idea that we could actually interfere with the disease itself before it manifests itself as a cavity could be interrupted. Because we think in dentistry of restorative treatment, which is important, it's essential. That's why we do it. But what if we could change the focus of the profession entirely so we're managing the disease, which is what most of medicine does, and that would bring us into the medical profession. Sorry, I said a lot.
No. Well, what you're saying is true. I mean, dentists are molar mechanics. They mechanically remove these infections, and all they talk about is how to fill in the hole with cement. And when you talked about ABCD, access baby child dentist, it's got to go all the way to when she finds out she's pregnant. Because when I talked to who used to be the executive director of the American Dental Association, now he's the head dentist.
Jim
Bremer.
Yeah, I can't remember his name right now. Jim, yeah.
Yeah,
Branson?
Jim Branson.
Yeah.
I listened to his lecture in Florida, and basically, a premature baby is their most expensive thing. It's $1 million.
Yeah.
And the number one thing they link it to is gingivitis, periodontal disease. And so that baby's in there. If when the body senses infection, somehow it's saying, get out, you need to get out of here.
Prostaglandins.
Yeah. So, and that's the time that not only should you be getting rid of the gingivitis and gum disease and treating all that, but that's when the family needs to be counseled, saying everybody in this family has got to get their oral health under control before this baby comes out. And when this baby comes out, we're not going to kiss it on the mouth. We're not going to sit there and take the bottle and say, that tastes good, then put it in there. We're not going to take food and blow on it and stick it in your mouth.
But
we're going to get out everybody's rotten teeth and gum disease and gum infection.
Well, I think the thing about kissing and all that, Paige Caulfield is the scientist who initiated that idea. He's, I think he's now at Ohio State, but he did that when he was at Alabama. He's a pediatric dentist and microbiologist, and he showed.
What's his name?
Paige Caulfield.
Cauffield.
Paige Caulfield, Cauffield. He's a brilliant guy. You ought to interview him sometime.
Yeah, pediatrician, microbiologist.
Pediatric dentist.
And
microbiologist.
In Alabama?
He's now I think he's in Ohio State now. He was at NYU after Alabama, and I think he's at Ohio State now, I believe. But I can find him, yeah. But he's a fascinating guy, and he's the guy that proposed this idea that a mother transmits her microbiome. He calls it the fidelity of transmission. In fact, he went all over the world and looked at the oral microbiome of babies and parents, and he found out that it was such high fidelity, the likelihood that you would get the mother's microbiome in your mouth, that he could tell you where your ancestors came from by looking at the bacteria in your mouth. He could take a sample of your bacteria today and say your ancestors came from this part of Africa 400 years ago, because that's how well it's transmitted from parent to child. So interesting stuff. But the thing about the mouth and the feeding, I think he doesn't particularly like that people say don't kiss your baby and all that, because it's almost impossible to avoid. But what he says is, because you're aware that if the mom's got a bunch of cavities and her mouth's rotten, that the kid's going to have that problem too, that we need to educate about, you're going to cause the problem that you had to your baby just because you have that mouth. And it might not be preventable. So just making them aware that you're going to have to, as you said earlier, Howard, everybody cares about their kid more than themselves sometimes. And so it's making them aware that, okay, you had this problem, but your kid doesn't have to have the problem.
Is that him?
That's Paige.
That's Paige.
Good man.
Unbelievable.
Brilliant.
Well, I need to get him on the show.
Yeah, he would do it. He would definitely do it. He's brilliant.
Can you email me that link, and we'll get Paige on the show? Because the parent would actually be more motivated. Like, say she was afraid of the dentist. Yeah. She'd be more motivated to suck it up buttercup for her baby than she would be for herself.
Yes.
I remember when, think of what parents do. How many parents did I know 30 years ago that at Christmas time they wouldn't exchange between the parents because the kid wanted a bicycle and a big wheel and,
right.
We're just the only reason we are here is to make babies who make babies who make babies.
Be fruitful and multiply.
Yeah. And, yeah, that would be. And then another thing, the orthodontists are just as bad. So, the dentists are just mechanically removing infection, and all they talk about is the bonding agent of their stupid cement. And instead of trying to go to this unborn baby and saying, let's try to make it not premature, let's bring in the whole family. They could be doing seminars in their office, like the first Thursday of every month, where if you're pregnant, come to my office, bring the whole family. We're going to talk about how to prevent dentistry instead of drill, fill, and bill. And there's dentists doing it. They're packing the house. Same thing with orthodontics. The anthropologists are telling us that Homo sapiens, a 2 million-year-old species, 100 billion have come and died before we were born. We're coming up on 8 billion now. And they're just finding malocclusions in like the last century or two. And it's because you were nursing. And when they fed him, here's a mastodon bone that the baby chewed on, and all these forces are spreading. Now, the first time baby has any difficulty, they switch to a sippy cup and a bottle with, it looks like, was made for a blue whale, and then the food is all processed, pureed stuff. So this kid has,
it's all about parents' convenience instead of what's right.
Yeah, there's no mammary gland force fight spreading the maxilla. He's not chewing on anything. So now this kid's at 14 years old and he needs 4 wisdom teeth pulled, 25% need another 4 bicuspids pulled, rapid palatal expanders. So we take all of our babies and put them through this 10,800 board certified orthodontist program because nobody has asked the question, why did no one need ortho the first 2 million years? And the orthodontists, they could be having a program saying, hey, last Friday of every month, if you're pregnant, come to my office and I'm going to teach you how to save, and you won't need ortho a decade from now. You'll save yourself $6,500 coming to my office. And then the law of abundancy, the more you give out, the more you'll care. Everybody will be talking about, oh yeah, we went to Dr. Joel Howard Berg's office, and I'm going to try to nurse her for a whole year, and we're not going to feed her applesauce, and we're going to go out and get roadkill and have the baby chew off bones. And
yeah, a lot of the things you're saying are, the evolution has occurred in part because of the behaviors we do. So evolution is adapting to behaviors. So who knows how much that is there. A lot of orthodontic problems are caused by early loss of baby teeth from caries. Again, going back to that age 1 visit. So, one of the main stories we tell people, which is based on good evidence, that if you don't take care of this kid's teeth, they're more likely to need orthodontic care because of space loss. Even a millimeter of space between the permanent first molars lost could be problematic. And you have a cavity in one baby tooth, interproximally, you could have enough space loss to make the difference. So those baby teeth are the best space maintainers. So there's a lot of connectivity to that preventive thing you're talking about.
The most, I would say, controversial thing in pediatric, there's not much controversy among pediatric dentists on Dental Town. Dental Town, I'd say of the 9 specialties, pediatric dentistry is the most robust. There's more pediatric specialties. The orthodontists, of course, they can't talk to the little people, so they had to make them their own Ortho Town, which you can only go on if you're an orthodontist. I can't even go on Ortho Town, and I own the damn site. They're a special club. Oral surgeons are great, endodontists are great, but pediatric is the most robust. The only
Do we have a pedo town?
No, we don't have a pedo town. But
we'll open it to anybody.
Well, we could. I don't know if you guys know this.
Dental town could be pedo town.
I don't know if people know this, but we made the ability. Dental Town is a 20-year-old website. I've had 5 programmers for 20 years. It's 500,000 lines of code. And we made it so you can cut and paste it and have your own, all the features of that thing, plus the app. And we host that for you. And we started doing that. That's how we had to make Ortho Town, Hygiene Town. And now I did one for my city called Tukey Town. But if someone out there listening wanted to do Pedo Town, we could do it. If say your wife was a quilter and wanted Quilting Town, and it wouldn't even have to have the name town in it, but I think if they all had the word town in it, it'd brand it better.
There's a pedo Facebook page called IPEDO that has around 4,000 pediatric dentists on it.
Yeah. The problem. I like Facebook. I'm on Facebook. The only thing I don't like about all the Facebook group is the we are the computerized bulletin board service forum. So I can go right to pediatric, the searchability. Facebook is just like, it hasn't changed since the beginning, which was email groups. You'd sign up for dentist at CompuServe, you'd open up your email and be 1,000 emails, and there was Internet Dental Forum and Root ZX, and it was just pure, I got to get this out of my email. So all MySpace and Friendster did, they just took it out of your email, and it's still that endless news feed, which hasn't changed on Facebook, Twitter, Instagram, LinkedIn. There's still just no organization. But the first social media was
kind of random, isn't it?
Was the computerized bulletin board system, which all the scientists, that came out in the 70s, so all the scientists who invented the internet, that's all they, when you go to NASA, you go to Jet Propulsion Laboratory, you go to anybody who wants to get something done, they're all on a bulletin board system. They're all on a forum. And as far as the endless news feed where you just open up Twitter and just tweet after tweet after tweet, that's fun and entertaining, and I like it. You see news headlines, you see things, you might click into. It's kind of like you might remember when cable television came out, and you thought, "Wow, I have 500 channels," but all you did is just scroll through all 500 channels.
I can't find one that I want to watch.
Yeah,
though.
you can't find that's what I think of when I think of Twitter and Facebook and LinkedIn. But like, let's say, but back to the deal. The only thing they're arguing about is silver diamine fluoride. But see, I can go to Dental Town. And I can go right to pediatric dentistry, or I can go do a search
for silver diamine
and silver diamine fluoride and pull up every thread, organized by last active one to least active. And then what's neat is, say 3 years later, some dental student wants to learn about something you guys are all talking about today. It's all right there. It's all organized.
It's great.
I think, and the other thing about Facebook is, you make a post on those groups, or you make a post on your page, all your people don't see it.
Right.
If you make a tweet on Twitter, Instagram, or LinkedIn, all your followers will see it. Mm-hmm. But on Facebook, it's all algorithms of what posts you make. And
we're starting to hear about that on the news.
And the only people that don't, all these people on Facebook are legends in their own mind, because they think, I got 5,000 followers and I made a post and 5,000 people saw it. Are you out of your mind? Only, what's the stat, Ryan, of what posts actually get seen? What percent? Facebook says 6% of your posts are seen by your followers. 6%. So you're basically in the bathroom talking to your mirror. Whereas on Dental Town or Twitter or LinkedIn or Instagram, like I got 15,000 followers on Instagram. I make a post there about we had a podcast. They'll all see it. I got 25,000 on Twitter. They'll all see it. I got 36,000 on LinkedIn. They'll all see it. I put it on Dental Town. They'll all see it. You put it on Facebook.
Yeah, it's random.
No one's going to see it unless you give them money and you boost the post. It was a bait and switch. It was, hey, join Facebook and spend all this time building your following, and then as soon as you build your following, when you make a post, you have to pay money for your following to see it.
Yeah.
So these guys that are if you're making a post on Facebook and you're not giving Facebook money, nobody's seeing it. About 6% are seeing it. Mm-hmm. And so that's why.
Do these limited sites have business interests that can purchase posts, or is it only limited to those?
What are you talking about?
So this IPEDO site, for example, could a company come in and buy an ad or push a message?
You could push an app. You could. Well, there's all kinds of tools you could do by zip code, by this. But I couldn't post this podcast and say everybody in the pedo groups see that. Now you could post it,
but only 6% would see it.
Unless you write on that post that says boost the post. Do you see that?
I'll look for that.
If you boosted the post,
but I have to pay for that.
Yeah. If you boosted the post for money, they'll show it all.
Interesting.
I mean, that's here's the twist. If you're on social media and you're not giving them any money, don't own the stock. If you're on social media and you're getting money, that's the stock you own. I mean, Facebook, the stock is amazing. The sales are amazing. The income is amazing because you have to give them money for anybody to see it. Like any podcast I do, I could easily buy my way to 100 to 200,000 views. I've had 10 that had over 190,000 views, but I had to get on my credit card for that. It's not organic. So the only secret to lower prices is lower costs. So you always want to lower your costs. But God, we're so down so many roads right now. Oh, back to the pediatric dentist.
Yeah, it's great. I love this.
The other reason I did that made it cut and paste and host on Dental Town is because there's 2 million dentists on the world. We only got 250,000 of them on Dental Town, and they're all English. And when I lecture in Cambodia and India and China, a lot of these people want different language. So if you think you're the social media king of Russia and you want a Russian town, Russian dental town, or anything like that, just email me, howard@dentaltown.com. We can do that. But again, it's silver diamine fluoride, and here's where it lies. So there's a lot of research that says, hey, it doesn't kill all the bugs, it just kills some of the bugs, it just delays, all those things. And there's no insurance code for it, and if they do charge, they're only getting 20 bucks.
Well, there is a code, but it's anyway.
But the other side of it is back to Facebook, the postings of children dying in the OR. So when anytime a child dies, there's pediatric dentist that says, well, why did you drag her to an OR? Why didn't you just paint it with silver diamine fluoride?
Yeah,
Why didn't you like? And then here's the other side of the controversy. There's only one company that sells it, Elevate Dental Care.
Another one just launched a product.
Well,
there'll be 3 or 4 by the end of this year.
Because the United States is a racket with the FDA. There's another one that's like silver diamine fluoride out of Australia.
That's correct. Just got launched.
But they're not going to go. But they've decided they're not going to pay money to go through the FDA to get it FDA approved to sell it in America.
No, they are. They are now. I just got contacted
They
just
are?
2 days ago.
Okay, well, that's
because
2
I'm
days
lecturing.
ago.
I'm lecturing.
Behind on my
no,
news.
I'm lecturing at the CDA next week on Friday, and they contacted me because they heard I was lecturing about medical management of caries, and I always talk about, amongst other things, silver diamine fluoride. So now that they have this product, they said, "Hey, we want to talk to you." So that's how I found out just the other day. I don't know when they launched it, but they've been trying for years because they have this.
Because the FDA.
Yeah, they have this second compound they put in there called potassium iodide.
Right.
That supposedly turns it white after it's black. There's some debate. I'll just say I don't know enough about it. There's some debate about whether it reduces the efficacy, and does it really make it white in perpetuity, or does it turn dark later? But to your point earlier, Howard, I think
Have you talked to Jeffrey Knight about that?
he's one of the developers of this new product.
But are you?
I have not. I've talked to Jeffrey a long time ago. I haven't talked to him in years.
Did you still have his contact? Because
I probably do.
Okay, yeah. So talk to Jeffrey Knight.
He's one of the inventors of that.
He's a scientist who happened to be a dentist. But anyway,
yeah, he's an interesting guy.
Out of Melbourne, where SDI is.
Yeah, exactly. He used to put. I remember he used to put Saran wrap on top of glass ionomer restorations to cure them, which was interesting to shape them, and he'd have the patients bite into occlusion with the Saran wrap while it was setting. It was an interesting idea conceptually. I don't know how it was practical clinically, but I remember him.
The only thing I don't like about him is he almost killed me.
Because you were in the car with him or something?
No, we were. When I lectured down in Melbourne last time, I'd climbed the tallest mountain in Africa. So he's like, "Well, you're in Australia, and we're in Melbourne, and the tallest mountain in Australia is only 3 hours away. I'm driving you there. That way, you can say you did Africa and Australia." So I thought, okay, and got there, and the area was closed because it had snowed like whatever, and we're sitting there climbing. I swear, you can't make this shit up. The snow was to our waist, and by the time I got there, the time we got to the top, I just fell down. And he's in like the best shape in the world.
Yeah.
I mean, this guy's, and he's sitting here yelling at me. He goes, I'm laying in the snow. I can't even. I'm done.
You got pictures?
And he's like, I don't know. And he's like, what are you gonna lay here and die? You freeze that? You idiot! Get up! He's yelling at me, get up, get up. So I finally got up, and so I got bragging rights.
All right.
I did the tallest mountain in Africa and Australia.
Congratulations on both of them.
But I would have, if I'd done it by myself, I would have been up there dead to this day.
Well, he didn't try to kill you, but let me just comment on what you said before. I think you raised a good point about the silver diamine, and I'll just try to be succinct. The two sides of the story you say. So I think the silver diamine fluoride is great. It's a wonderful innovation into the armamentarium of a practice. I have this slide I show that's called the medical management of dental caries. I'll send it to you. It shows the continuum of management, and the far right being operative dentistry, which is most of how we manage caries, the very late stage. But there's all this stuff that you could do, because every one of those caries lesions that resulted in a crown or an MOD or whatever it is started down here when you can't even see it at the microbiome level. So you have all these different places where you could intervene before it becomes a hole in a tooth. So that's the concept that I lay out. So if you think about silver diamine fluoride, it does kill bacteria. Silver is a powerful antibacterial. There's no question about that. They used to put it in kids' eyes to prevent transmission of sexually transmitted diseases at birth. Now we use antibiotics. But it's been used for war wounds, to prevent burn injuries from getting infected. But in any case, silver kills. But the problem is it's got to get to the lesion. It's got to get to the depth of the lesion. So there's a lot of debate and a lot of people who say, well, it's like holy water. It'll take care of anything. Well, nothing is perfect. It adds to our armamentarium. It's an important agent. I'm thrilled that we have it. But if I have a 2-year-old who's got 8 cavities that I can see, maybe I can't even see them clinically, but that they're much larger radiographically, there's no way I can get that fluid to the depth of those lesions. It's impossible. That kid needs restorative dentistry, okay? So I think it's important to have a balanced view to prevent a medically necessary treatment, to avoid a severe medical problem for that child. Some kids can't be benefited only with silver diamine fluoride. For some kids, you can delay what otherwise would be a general anesthetic episode till they're old enough to be cooperative, and they're not pre-cooperative, they're not cooperative. They're 4 years old, and they'll get in the chair, maybe we use nitrous, maybe we just give local anesthesia, and we can treat them. So we look at every situation uniquely, but it certainly doesn't eliminate the need for general anesthesia. That's a false statement. It gives us something else in our armamentarium to think about. So when I have a conversation with parents about I have this 2-year-old, and on an average day in practice with the residents in our program and students, we might see 80 kids. So on a given day, I might refer as many as 10 kids for general anesthesia. We have a very high risk population. Okay?
In
Seattle.
Yeah, I just wouldn't think of that as
Seattle.
About
poverty is related to it, although not all people who are on Medicaid
you think
are poor.
Amazon, Microsoft.
Well, we have
Boeing.
those too. We have
You think
mixture.
it'd be
We have
a
everybody.
rich shipping.
We
Cruise ships.
have Amazon patients. Our clinic is designed so we treat everybody. We have the kid. If I have 6 chairs in this bay, this kid's parents might work at Boeing or Amazon or Microsoft, and then I have 3 kids who are covered on Medicaid. Okay, we don't know. We don't care. I don't even care when I treat them. They're all the same. Nice. And I like the fact that we can treat them all the same. And yes, it's more likely that the kid who's on Medicaid is going to have that, but we have kids of all walks of life who end up in the OR at age 2. And it's all behavioral. It's all about sugar in the diet. It's all about sugar at the end of the day. It's all about sugar.
Well, let's go through what
but I think my thing is to finish SDF. Let's finish SDF real quick.
Okay.
It's a very important. I'm thrilled that we have it. It's going to expand medical management of caries, and it will allow us to avoid other treatments or delay them. But usually you still have to restore the tooth. Usually, in many cases, you still have to do it early, and it may require general anesthesia. So it gives me something else to put into the conversation with parents on many cases, but we decide based on what's best for that child.
Okay, so let's try to put them quantitatively in order. Variables. A 2-year-old comes into the OR. You got variables. You got transmission from the parents. You have diet. You have home care. You have water fluoridation. Mm-hmm. Put them in.
Yeah, I'm glad you asked. That's one of my favorite things to say. So the transmission one is in a category by itself because that's that is what it is. You can't control that. But of the things you can control.
Okay.
The next 3 are the order. You wrote them down in order. The ones that you can control.
Man.
They're in order. Diet, hygiene, fluoride. You can pump all the fluoride you want, but if the kid's eating sugar all day long, fluoride's not going to touch it. Nothing beats a bad diet.
And I also, one of the...
Diet is the worst.
I was a big part of the getting Phoenix fluoridated in 1989. In fact, the Arizona Dental Association gave me the Arizona Award for outstanding contribution to the profession.
Congratulations.
Yeah, and then 20 years we got it later. But then I lost all my... heart and soul about that when I was lecturing in Singapore and Tokyo, and the dentists there were saying Singapore's water fluoridation, Tokyo is not.
Right.
So there's a great control. Very similar Asian people.
Yeah, we see that across the U.S.
And their DMFT rates both drifted down evenly the same. And the people who showed me those charts and read me those papers was saying it was all went down. Their thought was the increase in home care from mother to child.
Yeah.
And that the child wasn't really doing the home care what the dad was doing, that the variable was with the mom. And as you educated the dental IQ of the mother, the pediatric dental decay went down.
I mean, health literacy. You're right, but what they're doing though is they're changing the diet, they're changing the hygiene, the way they brush the teeth. Care, yeah. And the thing about diet is all about frequency of sugar. Parents don't know that. Adults don't know it. Educated people don't know it. It has very little to do with how much sugar you eat, the risk of caries. Mm-hmm. It has everything to do with the frequency. If you sip on a cup of coffee that has 1 teaspoon of sugar and you sip all day long, you have a very high caries risk. But if you have 1 Coca-Cola at mealtime, you may have other problems. If you're having that 3 times a day when you otherwise take care of your teeth, your risk is low. So it's only about frequency, and that's what we need to talk about is frequency. On the hygiene, it's very clear, and I wrote an article for one of the dental hygiene journals a couple years ago about making everybody in the dental practice a personal trainer. That everybody, the front desk, everybody should be assigned to a patient because there's no gene that encodes for your ability to brush your teeth. Nobody knows how to brush their teeth. So how the heck are they going to brush their kids' teeth? So we make them brush their kids' teeth. I want to watch them do it and then take corrective action and then show them how to do it. So it's like going to a personal trainer. If I want to lose weight and get in shape, and I hire a trainer, a bad trainer is going to say, just go, here's a list, go lift these weights and come back and see me in a couple months. You're going to hurt yourself, you're not going to get anywhere. The good trainer is going to go through each exercise, watch you do it, say you're too slow, too fast, move this way. They're going to watch everything you do. That's what we need to do with toothbrushing. We have to be their personal trainer and show them how to do it because people don't know how to do it. I used to work for a toothbrush company.
Sonicare.
Yep, I know this. Nobody knows how to brush their teeth. I don't mean to be, except for dental hygienists. They can clean their teeth perfectly.
Well, I got my MBA from Arizona State University, where your two daughters went.
Right, great school.
They got their masters, and that's where that's my favorite gym. Right on Mill Avenue, it's a bar called Gym. So
really?
You can't lie. You say, I'm going to the gym. And
how's
then
it
you go
spelled?
there. GYM.
And it's a bar?
It's a bar.
That's funny.
So you might find out that your daughters have been misleading you for all these years, saying, yeah, Dad, I go to the gym 3 nights a week.
Oh, I drove by that campus the other day. So all these buildings going up. It's like a different world there now.
Yeah. Well, let's talk about home care because and toothpaste, because let me show you what's confusing to the dental students. There's a lot of research out there that says when you brush your teeth that the toothpaste isn't variable, that if you brush, dry brushing, you can brush for 2 minutes and remove all the plaque. So the toothpaste isn't necessary. A lot of other people say, no, the toothpaste is everything. It's the fluoride, the calcium.
The fluoride is necessary.
Yeah. So we solve that. You have to have toothpaste because the fluoride is necessary, not just for pediatric, but all ages.
Well, you need fluoride for all ages, okay? And it's not a matter of how much.
So you need to dentifrice with fluoride.
Absolutely. We tell
so
parents
all you dry
as soon as you have
brushes out
teeth.
there. So all the dry brushes are correct in that dry brushing for 2 minutes.
Well, there's two issues. There's two issues. There's the
fluoride.
fluoride effect, which you need, the drug effect, if you will, of fluoride. You need that tiny amounts. A lentil, I call it the legume family for a 6-month-old or 1-year-old, a lentil size, and then a pea when they're age 3, and then an edamame at age 6.
Oh, that's cool.
Nothing bigger than a lima bean.
You got a chart on that?
I think I do somewhere. I can send it to you.
Have you ever made a graphic though?
Yeah,
Ryan, make this. What do you call it? The
legume way of deciding how much toothpaste.
The legume way of deciding how much toothpaste.
So a lentil. I used to have a bag of lentils.
The legume way of deciding how much toothpaste. You got that, Ryan?
For up till age 3, you need a lentil. People say a smear or a pea size. Pea's too much for a 1-year-old.
Okay, so 1 to 3 is a lentil.
A lentil's tiny. I used to tell people, go to Costco, buy a bag of lentils, last your entire practice life. Give one to every parent to show how big it is. I used to give lentils away.
Let's do that, right? Let's go get all these legumes. So then, 1 to 3 is a lentil.
Right, and then 3 to 6, you can go to a pea.
A pea.
And then from 6 to 12, you can do edamame, which I love.
Now you're going to have to spell that. It's the sushi.
Yeah.
It's the green thing at the sushi bar. How do you spell it?
Edamame. Edamame.
God, let's have your. Let's go down. Okay.
And then you could go maybe to a lima bean or a fava bean. How's that? That was in the movie.
For 13 to.
Yeah, to adulthood. Okay, that's the most. You don't even need that much. You could stick with the edamame if you wanted. That's
13
plenty.
plus is a lima bean.
Yeah. Let's say lima bean. A little bit bigger than an edamame, but that's it. That's how much toothpaste.
And what bean is too big?
Oh, I don't know. What are those big beans? I don't know what they're called. Is it a fava bean? I don't know.
So I'm confused because my favorite bean is refried beans.
They're smashed
margarita.
Up. Well, they're all. But when you brush it on your teeth, it's a refried bean. Okay.
That is really cool. That was worth the whole life. I'm gonna make that with my. You know what I'm gonna do? We'll make those with our grandchildren.
Yeah, I mean, it makes them. It's something to think about. It also teaches people that when it comes to fluoride on your teeth, it's about dose, not if. It's how much. You know, the public, we talked earlier, Howard, about people not understanding statistics and, 1 death here, which is unfortunate, or this and that, but the relative or the accident that occurred in Tempe with the self-driving car, not considering 100 deaths in a day for humans driving. The example I give is when we had the anthrax scare back in 2001, there were, I don't remember that, I think there were 7 or 8 deaths in the United States from that anthrax that was sent in the mail, remember that? And the treatment for that is Cipro, the drug Cipro. So within 3 days, the entire world supply of Cipro was depleted. People in Kansas were buying Cipro, even though this happened in Washington, D.C. Okay, 7 people died. The chance of that person in Kansas getting anthrax was infinitesimally small. But every year, 30,000 people die from the flu, but nobody gets a flu shot. 30,000, it's actually more than 40,000 last year, die from the flu in the U.S., most of which is preventable with a flu shot. But it's not exciting, it's not in the news. So people hear something and they say, well, that's going to happen to me. You know what I mean? So statistics is one of the most poorly understood subjects.
It's because they always emotionally anchor.
It's emotionally anchored and not
Yes.
factually based.
Yeah, it's
so
all
fluoride
muscle.
is the same category. We have a lot of anti-fluoridationists, you know, and I talk about, look, it's a tiny amount. It's a naturally occurring agent. We're not talking about giving too much. You wouldn't give your kid 2 adult Tylenols. You'd give them a baby dose of Tylenol. The same thing with fluoride. It's all about dose. And to your point about needing a dentifrice to brush versus dry brush, you know, brushing your teeth, as I've learned, is a fluid dynamic and mechanical effect. And you have these fluid dynamics that help push the plaque away in addition to the physical force. So I think the dentifrice does stimulate the fluid dynamic effect a little more, in addition to having some mild abrasives. I think there is some evidence that it's additional plaque removal effect by adding a dentifrice.
But let's go back to Sonicare. People don't brush correctly 2 minutes in the morning, 2 minutes at night. Do you think the Sonicare, an ultrasonic toothbrush, some electric toothbrush is more effective than a manual?
I think that I always say now that the best toothbrush is the one that you use. Okay, so it gets down to what you said. Are you going to use it twice a day for the recommended time? And most people don't, and they don't do it properly. Most people can't brush properly. So if a manual brush makes it easier to do it properly, then that's a better brush for you. Sonicare or power brushes have the advantage of you still have to place the bristles in the right way. Positioning, there's positioning and movement. 2 parts to brushing, positioning and movement. If you position the bristles with the manual correctly and you move it correctly, you can get the same result, but most people don't position them correctly and they don't move it correctly, more importantly. The Sonicare or other power toothbrushes will do the movement for you, but you still have to position. Teeth are curved. You know, I always tell people when you want to wash the windows of a skyscraper, you could take a fire hose and just spray it with high pressure, but they're not going to get clean. So they pay people $100,000 a year to hang from the building and risk their lives with a squeegee, because that's the only way you can get that window clean. Where teeth are even harder because they're curved. So they're like that window. So the only way to do it is to have some contact with that surface. So what's the likelihood that an average person who isn't trained in dentistry, we know how to hold instruments and we know the contours of every tooth, is going to be able to get that there? So whatever makes it easier to do a good job is the right product. But we have to teach people that. Brushing is a lot less effective because people don't know how to do it.
This is Dentistry Uncensored, so I don't want to talk about anything that anybody agrees on. So let's go to the next massively controversial issue. People are all for sealants, but I mean, if you go to PubMed, you could literally find hundreds of articles that say that 40% of sealants have failed the first year and then 90% after year 2. I mean, why? So rant on sealants and rant to me on sealants when I'm already jaded because most of the research says they fail in a year or 2. Agree or disagree?
I disagree. It depends what research you're looking at. Okay, you can always find studies that support one side or the other, but if sealants are done correctly, that's the key.
But that's what dentists always say. When you say, okay, the average amalgam lasts twice as long as the average composite, then the dentist always going to come back and say, well, if he did it the way I did it. Well, I'm not talking about the way a board-certified pediatric dentist.
So the answer to your question is, you're right. If you just look at reality, I haven't seen those studies, and you look at what actually happens in practice, probably the biggest factor is not doing sealants when they should be done because of not believing it's going to be successful or whatever. But the literature, the fact is clear, and you're talking about reality, and I'm more and more I appreciate that than I used to.
Even Gordon Christian, when he evaluates a product, when these people always brag, I'm a CRA evaluator, they're so dumb because Gordon has a reality. Only like 10% would be like an A dentist. And then like 20% B, then like 60% C, D. So he has the full distribution. So some of my, I'll just say some people I know that always brag to everybody they're a CRA evaluator, they're on the F list. Because Gordon wants to know, what does the shitty dentist think of this? What does the D dentist? What does the C? So when some guy's bragging and wants you to buy him drinks at the bar because he's a CRA evaluator, first find out if he's an A, B, C, D, F. Because that's what that's the bias.
I can tell you that the science is clear that, and I understand your average dentist point for a lot of things. But if you place a rubber dam, which most people don't use, so let's go through a protocol
give me your protocol. Rubber dam.
I'm not saying you have to use rubber dam every time, but if you are unsure about your ability to control the moisture,
you know how I made every one of my dentists and hygienists practice under rubber dam 100% all the time.
I'm a big rubber dam fan.
But you know how I did it?
How?
I just went to each operatory and I tacked a rubber dam up on the ceiling, so they're always working under a rubber dam.
That's good. I think the biggest reason that dentists don't use rubber dam is because we don't, in dental school, everybody uses rubber dam, and they get out and only 20% do. And I think it's because we don't do a good enough job training them to train their auxiliaries to place it. Because, you know, if in the auxiliaries, and I think in Arizona, the law allows them to do it as well, to place the rubber dam. If I give the anesthetic, where I think dental hygienists can give anesthetic.
You know what? All those laws, I don't even like talking about those.
I don't even know. I don't even know the state.
They're never enforced. Like you say, a hygienist can't read an X-ray. Show me one hygienist in prison today from reading X-ray. Right. Your attorney general wakes up in the morning. They found some dead chick in a dumpster. Somebody murdered. Somebody torched a house, and the dentist is worried about, well, can my dental assistant place a rubber dam? And while he's thinking that, a car just drove by his office with 3 pounds of cocaine in the trunk.
Well, you're a realist.
My
that's why
staff does whatever they feel that treat other people like you want to be treated. If my dental assistant 30 years ago said, I want to place a rubber dam, I let her place a rubber dam. I didn't run to the legal center and start asking.
Yeah. Well, they can. I mean, but if the dental,
I think all laws are just suggestions written by stupid people.
Okay. But I think the rubber dam, if a rubber dam is used, the best protocol would be to use a rubber dam, but you can't always do it. Okay?
What about isolate?
Isolate works, and if you can visually look at the area and see that there's no contamination of the surface, physical contamination by saliva or water, then you have a pretty good shot at getting a good result with isolate. Remember that when you have isolate as opposed to rubber dam, you still have humidity. When you put the mirror in the patient's mouth, if it condenses on the mirror, there's humidity. It's 100% relative humidity. Maybe except in Arizona where it's dry. I didn't think about that. Maybe that's not true here. I'll have to test that. I hear you sweat a liter an hour. I told my wife, you got to drink a lot of water when you're sitting by the pool.
You just moved here. I got to warn you one thing. When this mountain you just came to, it's 42 miles around.
Yeah.
And then the next city over is Maricopa. It's 22 miles back. So those are my 2 3.5 hour bike rides. And if I leave in the dark, I can bike all the way around the mountain with no water. I can bike 22 miles to Maricopa and back if I leave the house at 4. The minute the sun cracks, you drink an entire deal of water every 30 minutes.
I agree with you.
And this is amazing. I've always wanted to do this. This is just it's too sadistic, psychotic, neurotic, but everyone says you cannot walk from Phoenix to Tucson, which is only 90 miles away, or run it or jog or anything without water. Wouldn't that be the coolest race in the world, Phoenix,
with
Arizona?
no water?
No water.
Why would you want to do that?
Well, I mean, it'd be a reality TV freak. Can you imagine? Everybody dies except one guy makes it to
I'd rather
the
eat 10 wings with no water. Go to the hot wing contest.
Yeah, so the desert, and the minute the sun's up, your evaporation is
it's like a liter an hour. It's crazy.
Yeah.
Well, anyway, so I think the rubber dam, there's some work done by Bob Fecal, who passed away a few years ago, a good scientist, pediatric dentist. He showed by adding the dentin bonding agent prior to placing the resin sealant that if there is some minor contamination from saliva contamination or even a tiny amount of water, that you could penetrate that dentin bonding agent with the sealant and have the same results in outcomes as you would by having a rubber dam. So I think what is taught now in most pediatric dental programs is, if you're not using a rubber dam, to place that dentin bonding agent first and then place the sealant. You'll have the same effect. So I think the studies you looked at that showed the poor results, and again, I understand reality. I think if those same dentists, if they're using isolite instead of rubber dam, which I understand, that they ought to try the dentin bonding technique. It just takes a few extra seconds. You etch it, you dry it, rinse it, you dry it, you place dentin bonding agent. It's like in a 4th generation adhesive. It'd be the dentin bonding component. It has the HEMA, the
program STA.
And you would then place the sealant. You'll get a good result. Fecal showed that very clearly in studies, and people follow that now.
How long have you been teaching pediatric dental residents?
Oh, it's been 33 years.
I wish you would make some online CE courses for us.
I would love to.
It's my biggest passion for a couple of reasons. We put up the millennials. They got $350,000 student loans. It's very expensive to fly across the country and go to a course.
I know.
We put up these courses and they're like $18. We put up 400 courses. They're coming up on 1 million views. But why I'm so passionate about it is we only charge people in the rich countries. So when I go to places like, when I lecture in like Ethiopia, Somalia, Tanzania.
They get free access?
Yeah, and I walked in Kathmandu, and when the dean realized I was that guy, she started crying. She said all of her textbooks are 20 years old, and she goes, those 400 Dental Town courses are her everything.
That's a beautiful place. I want to go there and visit that.
And then I was just in South Africa and Cambodia and Indonesia, and I was in South Africa. And when most people, when they're a place they want to shop or whatever, I just want to see dental offices. And I've seen dental offices in 50 countries. And I was in South Africa, 3 different dental offices. And I'm not talking about in the rich Johannesburg or whatever. I'm talking about out in the countryside. And I walked in, and this guy took a deeper look at me, and he goes, "Are you Howard?" And I said, "Yeah." He goes, "Those courses," he goes, "I thought I was a great dentist, and I thought I went to one of the best schools in South Africa." He goes, "But that was 20 years ago." He says, "I watched every single one of those 400 courses." He hugged me for like 5 minutes. We are transferring so much knowledge.
To stay up to date, you have to do
from
this.
the first world to the underprivileged worlds.
Yeah.
Who live under dictators and crazy people and all that stuff. But it's so you would be doing this course, and this would be India has 4 dental schools for everyone in America.
Well, they have 18 in Bangalore. I've been there and lectured, and I've been there many times, and they have 18 dental schools in one city.
So every one of them would be watching that course.
Yeah, they have. There's a lot of need all over the world. It's great that you do that.
Well, no, I think Steve Jobs. I mean, when you and I got out of high school, this was an IBM mainframe that only a rich corporation or government could have.
Right.
And now 3.5 billion people got it in their pocket.
Right.
And I think 2007 invention of the smartphone, to the next century, 2107, will be humanity's finest century.
Oh, well.
Because knowledge is going to zero cost.
Yeah.
Where 100 years ago, only the richest people got to go to college.
Right. Now
the poorest person in Bangalore
has a cell phone.
Has more access to unlimited free information.
There are more cell phones in the world than there are toothbrushes.
Yeah.
So.
Yeah. Fred Margolis. Friend, thoughts?
I don't know him well, but he's been instrumental in education in pediatric dentistry.
He passed away.
I know. Yep.
I thought he was. I always credit him bringing lasers to pediatric dentistry.
I don't know who brought lasers to pediatric dentistry. There are quite a few people that talk about it.
Well, he brought it to the forefront.
And there's a lot of people who use lasers, and that's another subject.
No, well, come on. You got to go. Are you?
I have to go in a little bit. I have to go get my wife for a little bit to take her somewhere.
So he can stay all day. Just be in the doghouse. Well, you got to talk about lasers because that's a big decision. You come out of dental school, $400,000 in debt. Now you go to pediatric dental school, another 3 years of debt, and then you come out and they're wondering, should I buy this $100,000 laser? No shot, no drill, pediatric.
There are a lot of people who swear by it, and every year at our meeting we'll have like one lecture on lasers, and they'll say you can use it for everything, and I've eliminated my burrs and handpieces and only use lasers now for all my preps. But it hasn't hit the mainstream yet, for a reason, I think.
What do you think the tipping point is in dentistry? 5% of dentists will buy anything. In Wall Street, the tipping point's 20%. What do you think the tipping point is in pediatric dentistry before something takes off? Like what percent of pediatric dentists today use silver diamine fluoride, would you say?
The vast majority. In a year, it's that
what percent of dentists have a laser?
I don't know the answer, but it's low. It's definitely below 20%, I would say. 20% probably is about the tipping point for us too, I would think. And I was in industry, I saw that phenomenon.
How the 80-20 rule always shows up.
Yeah, no, I believe that. It's just human behavior.
So how much more time do I have? Just tell me the truth.
Just a few minutes if we...
Okay, a few minutes. Okay, let's wrap it up.
Yeah.
You said you give me an hour. I've only taken an hour 10.
Yeah,
now you're
I'd love to come back and do the...
Final question. The business of dentistry. How are market forces changing the way we practice from when you and I were little?
This is fascinating. This is one of my favorite subjects.
Final question also.
So when I lecture, I talk about the biggest changes in our profession. One of them is medical management of caries, and we talked a lot about that. One is big data. We talked a little bit about that, but that's another. We could talk 2 hours about clinical decision making based on outcomes of everybody. So if I have a patient in my chair who's 8 years old, and they're going to exfoliate this tooth in 3 years. And I want to know whether should I do a composite on this, or should I do glass ionomer, or should I do a stainless steel crown? What if I had access to 6,000 cases, exactly same demographics, same situation as this one, and instantaneously I could look at what were the outcomes of having chosen A, B, or C? Instantaneously.
You're talking about machine learning, or artificial intelligence.
It's talking about decision-making, clinical decision-making based on informatics. And the data's there. Everybody has their software. If we could de-identify it, pull it, and I mean, Facebook's doing it. You know, everybody else has data. So data mining. But that's the second big area. But the third biggest area is the payer system. You know, dentistry is a fee-for-service business. But who's driving the cost of healthcare? Well, you remember about a month ago, there was an announcement made by Jeff Bezos and what's the guy from Warren Buffett, and then Jamie Dimon, right? They say we have 1 million employees. We're spending too much money on healthcare. Buried in there is dentistry, by the way, and their papers. Nobody's disclosed. They haven't disclosed what they're going to do, but they're spending a fortune. They're the biggest purchaser of dental care in Washington State. Amazon is, okay. Amazon's got 400,000 employees and growing 50,000 a year. Their HR department has 1,200 people in it. HR department has 1,200 people in it. You know, and every one of them.
And
has,
the first company that'll Amazon, Apple, hit $1 trillion market cap.
Yeah, and they're self-insured. All these companies. So when they go and they purchase from Delta or wherever, they hire somebody to manage their plan. They're paying the cost. It comes from the dental insurance company, but they're actually paying that money for that filling. They're self-insured. So if suddenly everybody got cavities the next year, everybody started eating sugar at Amazon, they'd pay a lot more money to fill those teeth. So they're noticing the costs, medical and dental, and they're saying we need an innovative model because we're paying these bills. And the same thing with Boeing, and the same thing with T-Mobile, and all these big companies. So that's going to, that's the market forces that are going to drive costs. Are first going to look at children and how we can prevent. So going back to our first thing we talked about. They're going to say, well, okay, we have priorities. Kids got to be first. We got to prevent this disease so when they become adults, they'll be more productive citizens. They don't want them not showing up to work when they're adults because they have a toothache. That costs them a lot of money. They want to improve oral health. So they're going to start paying more attention to how can we improve oral health by prevention, by early intervention, instead of just waiting for the manifestation of the disease. And I think the market is positioned to do that. And I think this announcement by those three guys, dental's got to be included in that conversation, and it will be, because it's not cheap.
Do you think when Obamacare, when Obama was rolling out the Affordable Health Care Act, do you think he should have mandated water fluoridation? It's a federal law that salt has to be iodized to get rid of goiter. It's a federal law that breads have to have B6 and riboflavin to get rid of beriberi. So much of this is all federal law. The only one that they decided, let each single city, state decide.
Well, the difference,
because of the politics of it, it was a communist bloc.
Yeah, I think there is that.
Or do you think it's not therapeutic?
Water fluoridation would be great. Although going back to our list, the diet is the biggest factor. Yeah. Fluoride, as you saw in the two communities example, it definitely makes a difference in a population. You can see that a community which is fluoridated. I always say that if you blindfolded me and put me on an airplane and dragged me to a dental office and selected 100 kids randomly from that office, and I didn't know where I was, by the time I got to the 10th kid, I could tell you if the community was fluoridated or not. That's how powerful it is for a community. Right. But for an individual person, not for a population, the diet is the most important thing. Right. So I think, early intervention and education, health literacy are the most important things. And the Affordable Care Act did do some good things for kids, but for adults, they're left hanging. I mean, Medicare, dentistry is not part of it. And whether that's good or bad, we can debate that.
And when you do these chromosome crowns, the mother's so upset because they're so ugly. I mean, they're metal and they say L4 on the side of it. Yeah. There's some new white tooth.
Yeah, there's zirconia.
Zirconia. Is that Nucor?
There's 3 or 4 different companies.
Can you name them?
New Smile.
New Smile
is the biggest one, and there
out
are
of Houston.
Exactly, and there are many others that are very good. They're prefabricated. There's 6 sizes. The challenge there is, because there's 6 prefabricated sizes, you got to cut the tooth smaller than you would like to fit the size, rather than custom making. But there's some new technologies that I'm following that are very interesting. People out of the orthopedic business, and I can't disclose too much because they told me not to talk about it. But I can just tell you that they're looking at ways for permanent teeth, and I said do it with baby teeth, to have a patient come in, scan them before you cut the prep, scan the teeth. They make a crown to fit the tooth after it's prepped, and they have a jig that will ultimately cut it for you with robots. But for the foreseeable future,
nice.
For the foreseeable future, it'll actually have like a, kind of like I guess with implants, you could have like a surgical guide. So kind of like a surgical guide with a special burr that's designed for that tooth, for that patient. So when you cut the prep, this crown they just made will fit.
Can you disclose the company?
I can tell you within a month. I think they're going to be.
Hey, you've got to be one of the most connected people in dentistry.
When I was in industry for 10 years, the asset I gained that I value the most, and I think you would understand this, is the people I met. Yeah. Interesting people like you, and I never would have met you if it weren't for my industry days. And I think that just the more people you meet, I always say we have a problem in dentistry, this caries problem. The solution is not going to come within our profession, it's going to come from outside. So the more people and areas you can discover, the more scientists you can discover who are in this field, the better. If I have just a minute,
you have all day.
Okay, I'll conclude with this one. I went to a lunch about...
just don't think about your wife.
Okay.
Don't think about your wife. She's not going to leave you over this. She might bitch and moan, but she ain't going to leave you over it.
Okay. So about 7 years ago, the president of the University of Washington at the time, he's now the president of the NCAA, Mark Emmert. He was into like seeding ideas interdisciplinary across campus. That was a great idea. So he set up these lunches where he invited people from different parts of the campus. So I was sitting at a table with 5 people. One guy was a geologist, one person was an astronomer, somebody was a sociologist, and this other guy was a mechanical engineer. So we each supposed to spend like 1 minute saying what we're interested in. So I talked about early childhood caries, this big growing crisis, and this guy, Eric Seibel, said to me, well, I thought cavities were done in kids. My kids don't have any. I said, I would have guessed that they don't. But he goes, actually, they're worse now. So I said, so he's talked about what he does. He's a mechanical engineer. He's designed this device called the scanning fiber endoscope. And it's a tiny fiber. You can make it less than 1 millimeter in diameter, a fiber optic thing, at the end of which is an HD camera. And so he can take this camera, insert it, and he's been using it for endoscopy of the stomach without sedation. I saw it on a video. Patient can talk, no sedation, and you get high-resolution imaging of the stomach. They're looking at the fact that some ovarian cancers start in the fallopian tubes and then seed to the ovaries. The first non-invasive, possibly way of screening for that with a tiny HD camera. So we talked about teeth, interproximal lesions. He can put fluorescence in there and look at the early caries lesions. Maybe we can look interproximally without separating the teeth even. So now fast forward, he got a group together, we got a grant. He's now got a National Science Foundation, I think $1 million grant. He's had several grants, a PhD student complete his PhD in this, and he is designing, and once he gets some more funding, a device that could detect caries lesions and then maybe treat them and then follow up the effect of your treatments with certain agents that are yet to be developed before they've formed cavities, early lesions, seeing them formed at the early stages in enamel. And on his team is a guy, this is fascinating, this guy was an expert in fluorescence. He was involved in designing the cockpit display on the 777 airplane for Boeing. He's retired from Boeing. Actually, he was a subcontractor. He didn't work for Boeing, but he designed that display. It's all black until you turn the power on. Then it's fluorescence that lights up the screen. So he's an expert. He's read all the caries literature. This guy knows more about caries than me and most dentists who I've met. And he is passionate, and he's got an entire team around this to develop this device to see those lesions early. So this is a guy who thought we didn't even have a problem. Now, 7 years later, he's got this team of people, none of whom are dentists, engineers, students getting PhDs around this caries subject, and it's growing. So the more people like that get involved, so that's why I love meeting people who have expertise, hopefully even outside our profession, that can help us. We help each other. So I think there's a great future by, meeting interesting people.
Well, send me names and links to any of these contacts that you think
Eric,
should come
you can
on the
interview
show.
Eric. And you should talk to him, the guy that developed that device.
Did you find it, Ryan?
Look up. It's called the Human Photonics Lab.
In Seattle.
In the University of Washington. The Human
Photonics Lab. And the guy's name is
Eric Seibel, S-E-I-B-E-L.
S-E-I-B-E-L.
Yeah, he's the chief guy in the lab.
So, speaking of Boeing, you mentioned Boeing and that. Did you think it was bizarre that Boeing Seattle, that they moved their headquarters to Washington, D.C.?
You know, people.
I mean Chicago.
Yeah, I mean, they have a small footprint there, but it's the official headquarters. I don't know. People said it was because of the unions and this and that. I don't know. But at the time, it was a big deal, but now it seems like not a big deal because there's not many employees. Most employees are still in Seattle. There's some in South Carolina for the 787 manufacturing.
Oh, I thought that was very bizarre.
Yeah.
If I was the CEO of the company, I'd want to be right where all my workers were.
And they said it was because of easier access to the airport in Chicago to various parts of the world. You know, there's more direct flights, things like, I don't know, who knows why.
And where do you think Amazon's second headquarter will be?
Your guess is good as mine.
Really?
I call Jeff Bezos every day. We talk about it. I don't have any idea, but
where would you guess?
You know, I think Washington D.C.
Yeah, he bought a home there, dude. You got to watch the monkey.
I mean, he owns the Washington Post.
You got to watch the monkey.
Yeah, I think Washington D.C. or that area is probably going to be.
People get all caught up in all this weird stuff. He's a human.
Yeah,
he just bought a house in Washington D.C.
In a gigantic,
he bought the Washington Post. So it's going to be. It's going to be within a 30-minute commute from his house. I agree.
It might be in Virginia. Yeah. It'll be somewhere in that area. Yeah.
You are so fascinating, but I think we can agree. I mean, a lot of people might think you're the greatest pediatric dentist that ever lived.
No.
But
I know a lot of them.
I think it's Jeanette McLean.
Jeanette's great. I had lunch
she
with
made
her.
the cover of the New York Times.
Yeah.
She is my favorite PI. So I don't want to.
I don't want to hurt your feelings. I had lunch with her last week with other people.
She is so passionate.
Yeah, she's very passionate about the silver diamine fluoride and things like that. Yeah, and she's young, and I think she'll shape this kind of. She'll help.
Well, everyone's young to us.
Yeah, well, it's true. She'll be one of those that shapes this future we're talking about. Yeah.
Well, I just love her passion.
Yeah, she's terrific.
I mean, the woman eats, lives, breathes, dies pediatric dentist around the clock.
She does. You know, and I think Jeanette's great. I'm going to our annual meeting next week. Is our annual meeting in week after next in Honolulu, the APD meeting. We'll have a great attendance there.
When's it going to be?
Starts on the 23rd on May, 23rd of May till the 28th of May.
Now, will the blue whales be coming through there?
I have no idea.
Okay, in the winter, when everybody visits Hawaii, you just have the sperm whales, which are huge. But in the summer, June is the largest creature that ever lived on the planet Earth.
I'd love to see a blue whale.
Larger than any dinosaur that ever lived.
I'd love to see a blue whale.
But you know what? When I saw the first one, I couldn't breathe and my heart stopped.
It's unbelievable.
They're the size of a semi-truck. His pupil is bigger than your head.
It's like they eat plankton, though.
But I think they come in June. But Google that.
I'll Google it. I like to see them.
Because if you were there like the 25th or the 28th, and it turns out that those whales were coming 3 days later, and you missed that. It's like the Serengeti. I'm telling you, you all like the Lion King, you all like Disney. I mean, when you go to the zoo and you see a hippo. When you go to the Serengeti and you see a million birds take off at once. When you look over in a pond and there's 50 hippos. The guide stops and says, and it says, right, and you're looking, and you're like, where, what? The tree, and you're looking at the tree, what? What? You look at the tree, what? He said, just shut up and stare at the tree. And you're like, look at the tree. And then you see a giraffe in it. I mean, it is so... But those blue whales were bigger than any Tyrannosaurus Rex.
I want to see one.
And
it
was my first, besides with a dog or a cat, because I can talk to both. I had my first interspecies contact, non-dog cat with a blue whale.
Can I tell you
the story? So you're going out there, and then you stop because they can't get too close. And if you're lucky, the boat's legal. It stops, but the whales start coming your way.
Yeah.
This little baby, and by baby, I'm talking about 20 feet long, this huge thing. And he starts swimming. The guy's like, be quiet, a baby's coming. And it comes, and it swam around, and then it got right on the side of the deal, and it turned on the side. That's when I saw his eye. And then he turned around again, and he saw his eye, and he just looked at us. I mean, he's looking right at us, and he's like, oh my God. Does it again. Then all of a sudden, 100 yards away, this big old mama lifts her butt out and smacks that water, and that baby just shot over to her. I mean, I never seen a baby, and you just knew that little baby, his mama just yelled, get your butt back home right now, or I'm going to smack you. I mean, you could tell that baby's like, oh my God, I'm in trouble.
Yeah.
And we just all sat there, and I mean, it was raising 4 kids. I mean, I saw that behavior.
Same thing.
It's just the same thing.
Same thing.
I mean,
dogs,
that is
all species.
Human.
Yeah.
Total human.
See it all.
And his brain's, bigger than both of our cars combined?
Yeah, they're big.
Oh my God, you can't, if you're going to be
All right,
that
I'll check
far,
on it.
find the dates.
Okay. Thank you, Howard, for this opportunity.
Oh, and your Rolodex. I'll love your Rolodex. Anybody you think that my homies would love to listen to,
Okay.
Send me an email, their links, invite them. We can do it over Skype long distance if they're in Phoenix, probably by the house.
Okay.
But seriously, you've been a big mentor of mine for 3 decades. Thank you for all that you've done for me personally and for the sovereign profession of dentistry.
Thank you. Appreciate it.
All right,
Thank you so
buddy.
much.